Sounds good. All right. Would you like me to go ahead and proceed?
I would. There are 14 people viewing.
Yep.
All right. Okay. Perfect. Well, I guess I'd like to, start by wishing you all happy holidays, and really thanking you for all of your support. Of not just my practice, but of the orthopedic partners and all of us over here. I don't think we probably get a chance to interface as much as we'd like to, except for on quick phone calls with patient consultations and referrals, and the practice of essentially ski and trauma medicine on the Wasatch back. And so I just want to say thank you to all of you for at times your patience with us, but most of all for your support. And I personally, but as a partnership, I think we just want to say thank you. We really do appreciate your support. And with that said,
Charlie,
go ahead. Yeah.
I wanted to say just 2 or 3 words because I know your time is short. The rest of the group that's on here needs to know that Charlie's been consulting for us from when we were still over in Bonanza. And when he first came to town, he even came into our clinic and did things all the time. He's been wonderful in that we can call him anytime or send pictures, and he'll say, this doesn't need surgery, this does need surgery. And so I'm glad to hear you appreciate us, but you need to know how much we appreciate you. And that's all I'm going to say because your time is limited. But thank you.
No, thank you, Winnie. And thank you for the invitation to talk about this. Tibial plateau fractures have kind of become a sweet spot for me in my practice. I actually enjoy taking care of these injuries. They are challenging. They do present some challenges. No fracture is like the other. And so with every one that comes across the table, I feel like there are some little kind of things that you can trip up on. So it requires quite a bit of diligence, from the orthopedic surgeon that's taking care of these injuries to make sure that we don't miss things and that they get treated appropriately. Some are very straightforward, but others clearly are not. And so my objective this morning in presenting this topic to you is probably not to cover A to Z. That would be difficult, but rather to give you an idea of kind of my thoughts as it relates to, seeing and evaluating these at first blush. So, trying to put myself in your shoes a little bit as this patient presents to me off the mountain or, by whatever mechanism it happens, and what those considerations are. And then maybe give you some ideas for, what kind of care that patient's receiving once they reach me or one of my colleagues here. In terms of how we manage them. I don't have a great amount of detail there. That might be a topic for another day if we wanted to go that direction. But with that said, we'll kind of dive into it here. So, in establishing the diagnosis of a tibial plateau fracture, when that patient presents initially with the acute knee injury, there's obviously certain things you're looking for in the mechanism that would be, oh boy, sometimes it's obvious, sometimes it's not as obvious. I do see patients come into my office that, are kind of provisionally diagnosed with a knee sprain, right? Just kind of a generic knee sprain or an MCL sprain. And we get an x-ray. They may not have even had an x-ray, but most of the time they do, obviously. But on close inspection, sure enough, there's a tibial plateau fracture that explains their injury and their effusion, and it's not so much of a ligamentous injury or a sprain. So high index of suspicion just based on mechanism. Mechanism for tibial plateau fracture isn't that much different than it might be for a ligamentous injury of the knee. The one thing that may be somewhat unique about a tibial plateau fracture that I didn't actually list here is an axial load. So if the patient is in kind of a G-force situation where they're really loading their knee aggressively at the time of injury, your suspicion for plateau fracture should go up a little bit. It is oftentimes associated with mechanical sensations, just like a ligamentous injury might be. We get so used to the classic, ACL injury description of backseat or, other position while you're on your skis and a pop, and kind of a shifting sensation. But oftentimes patients with plateau fractures obviously describe the same thing, especially if it's not a real profound one. If it's a subtle depression, that can present with the exact same historical description as a ligamentous injury of the knee. The difference is that oftentimes after a plateau fracture, even the subtle ones, patient can't wait, Bear. Obviously, the bigger ones, it's obvious, but that's the one thing that might separate that and increase your index of suspicion that they have a subtle tibial plateau fracture if they really do have trouble weight bearing right after the injury. On exam, you're going to appreciate acute effusion and hemarthrosis. Difference between a plateau fracture ligamentous injury is you may see some, swelling about the proximal leg, not just a knee effusion, tense effusion, but if you look a little closer, you're going to see some swelling about the leg. You're not going to be able to range the knee very well, like you might be able to in a ligamentous injury situation. They're going to hurt, so they're going to be very, very guarded. It's going to be very difficult to perform a stability exam. If the injury is obvious, there's no need to obviously try to perform a stability exam. Even in the setting of a depressed lateral tibial plateau, let's say without a split, and we'll get into that here in a second, their stability may be absolutely normal, so that exam isn't going to give you a ton of information. If they can tolerate it, obviously you want to examine for ligamentous injuries, but if the injury is obvious, you don't necessarily need to go to that extent. Probably the most important piece of the exam, once you've kind of established that it's a significant plateau fracture, is a detailed neurovascular exam. Sometimes it's hard to get, as representative of an exam as you would like because they're hurting so much, but it is important to make sure that they have palpable pulses and that they're symmetric to the contralateral side. And I'll come back to that in a bit. And why that's important and what we may do if it's asymmetric. With any tibial plateau fracture, especially the higher energy ones, and again, we'll come back to this, there needs to be an index of suspicion for vascular injury. They do happen, just like they happen in knee dislocations. And so you kind of want to treat that patient with the more significant tibial plateau fractures, very similar to how you might handle a knee dislocation with a high index of suspicion for a vascular primarily or a nerve injury. Imaging, obviously every acute knee injury needs an x-ray. And this is where I might emphasize that, anytime we're looking at a long bone fracture, the gold standard is to make sure that you image the joint above and also the joint below. So many times when I get consulted from the emergency department or, obviously a ski clinic, we have an x-ray of the injury, but we don't have much detail outside of that. And what could really help us on the receiving end sometimes of these patients is to ensure that we have thorough imaging. It's best to do it right at the time when you're doing the obvious injury imaging. A tibial plateau fracture should get an AP and lateral of the tibia and fibula. And if there's any ankle pain or swelling, they should get an ankle x-ray as well. Obviously, if there's thigh pain that would lead you to suspect anything going on with the femur or hip, you should look at that as well. These are obviously the high grade ones, very painful. And so we want to make sure that it's obviously a distracting injury. And so we want to make sure that we're imaging appropriately, because we do receive patients and then at time of surgery, or just beforehand, or sometimes even after, unfortunately, identify a secondary injury like a medial malleolus fracture or kind of a non-displaced distal third tibial shaft fracture associated with these. And so it helps us and obviously keeps us out of harm's way and trouble from making medical errors if we have good imaging beforehand. The gold standard for any tibial plateau fracture is obviously CT scan. And I have really enjoyed using 3D CT scans to help me. I use these all the time intraoperatively. These are my bread and butter imaging. As I'm doing the procedure, I'm constantly referencing these images, rotating it around, playing with it to understand the dynamics of the fracture and what I need to do. So if you're ever in a position where you're going to go ahead and order a CT scan, even if it's not for us, if it's a patient that is stable enough that they can return to where they're from, oftentimes in the wintertime, but you're ordering a CT, I would always order it with 3D reconstructions, because it really does help, in my opinion, the surgeon quite a bit. And obviously it saves a step that you would then have to do. So I'm always actually ordering these on patients if they don't have them when they present to me, or I'm calling radiology, asking them if they can do the 3D reconstructions to help me. So I just went over that. So when we're looking at a tibial plateau fracture on x-ray, the classic classification system, which obviously, in orthopedics, we love these classification systems because it helps us plan our surgical treatment plan. And so this is the classic classification system for proximal tibia or tibial plateau fractures that pretty much every orthopedic surgeon is familiar with. There are other classifications as well, the AO classification and others, but this is the one that we utilize in terms of language and semantics to communicate with one another. And so I'd like to just kind of take you through this so that you understand what it is, because oftentimes, I'll get told, oh, it's a Schatzker 6. It's like every tibial plateau fracture is a Schatzker 6, if it involves both condyles, but that's not necessarily the case. So type 1 is a simple split, okay? Type 2 is a split, and then there's articular depression as well. Can you guys see my pointer?
Yes, we can.
Oh, good. Okay. Type 3 is a simple depression. Type 4, we're going to talk more about this injury because this is more significant than we oftentimes appreciate, but this is oftentimes a unicondylar fracture of the medial condyle, but there's oftentimes associated depression that can extend through the eminence portion of the tibia and even into the lateral plateau, because what happens is the lateral condyle of the femur kind of gets buried on the medial side of the tibia. And so it's a little more than a medial condyle. A type 5 is bicondylar, but the difference between a type 5 and a type 6 is metadiaphyseal dissociation. And so here you can see in the type 6 injury that you've got dissociation of the metaphysis from the diaphysis of the tibia. And this is an important consideration when we talk about surgical stabilization. But the type 5, this all remains intact. And so this is highly unstable. These oftentimes have reasonable stability to them. All right, so I just want to take you through a few x-rays. The reason I put this up is the tibia fracture. And this is what, if we're communicating via the telephone and you say, oh, yep, I have a 43-year-old male, fell skiing, and sustained a tib fib. Everybody likes to say a tib fib fracture. And when we, from an orthopedic surgery perspective, when we communicate about this fracture, for example, we don't really talk about the fibula. We say tibial shaft. For example, I have a 43-year-old who has a distal third right tibial shaft fracture. And what that means to me when I hear that is that, oh, that's a patient that has no articular involvement of the distal tibia or of the proximal tibia, and I'm going to be able to stabilize that fracture most likely with an intramedullary nail. So many times I get, in conversations with the emergency department and others, I get tibial plateau fractures or others described as a tib fib. And my point with that is that, proximal tibia fractures that involve the articular surface, that's not a tib fib. And so when you say tib fib, this is the image that comes in my mind, as opposed to a tibial plateau fracture. And so we're going to go through a couple x-rays here to just kind of describe injuries. So I guess I would ask somebody in the group if they would volunteer to describe this injury to me. So if this patient presented, how would this injury be described? Is this a tibial plateau fracture? How would we describe this? Any volunteers?
Charlie, that looks like an avulsion of the tibial tuberosity. Looks like a skeletally immature patient. It looks like they've just taken off that apophysis, but maybe not extending into the joint necessarily.
Perfect. So, right, this is not a tibial plateau fracture. This is a tibial tubercle avulsion fracture and is most common, you're absolutely right, in skeletally immature patients. But I've had, this injury described to me as a tibial plateau fracture. How about these? So the reason I put this slide in is that these could be tibial plateau fractures, right? This is a little more gray because, I don't have an x-ray, but if this presented on x-ray, my initial thought is if I looked at this initial on an x-ray, I'd think, oh, that's a tibial plateau fracture. But if you get a CT scan and there's no involvement of the articular surface, this would be a proximal tibial shaft fracture. And this is a fracture that could be treated with an intramedullary nail potentially, although probably not. It would be treated similar to, the one here on our left would be potentially treated with an intramedullary device. The one with all the comminution would likely be treated similar to a tibial plateau fracture with plate and screw fixation. But if any of these present, you would certainly want to get a CT scan, because even though it may not appear on an x-ray to be a tibial plateau fracture, it certainly could be, and we would want to define that intra-articular component to ensure that we're treating it appropriately, because that's for sure going to be a consideration. So the reason I put this in is that this would be a segmental tibial shaft fracture, and oftentimes these will be quite proximal and may have extension into the tibial plateau, but this would simply be described as a segmental tibial shaft fracture, and this would also likely be treated with an intramedullary nail. So this is one too that I feel like is a kind of a recurring theme, where this patient will present to our clinic oftentimes, not necessarily, at the same time. I don't necessarily receive calls from y'all about this particular injury. I think it's oftentimes diagnosed correctly, but when this patient presents to our clinic, oftentimes it will be kind of provisionally booked on our schedule as a tibial plateau fracture. And so my point is that a lot of eminence fractures, ACL avulsion injuries, get described as a tibial plateau fracture, when really this, as you know, is a variant of an ACL injury, simply an avulsion fracture of the tibial eminence. So this would be a tibial eminence fracture, not described as a tibial plateau fracture. So here, the reason I put this in is this is your Schatzker 5, right? Where you see connection of the diaphysis to the metaphysis of the proximal tibia with both medial and lateral condylar involvement. This is a tough one, right? This is a Schatzker 6. And Schatzker 6, as you know, they come in all different variations. The comminution can extend quite distal, etc. But this is a true Schatzker 6, where you have all this comminution of the metadiaphysis. And so this is obviously going to be a highly, highly unstable injury. And this is one that we would treat clinically at initial blush, just like a knee dislocation. And we're gonna circle back to that. Here's your knee dislocation. And the reason I put this x-ray in here, sorry, that's a terrible image. That's just one off Google. That's a good one, I thought. But the reason I put this in here is that this is what our brain should think of when we see a highly comminuted tibial plateau fracture, or Schatzker 6, or quite frankly, a Schatzker 4. A Schatzker 4, the medial condyle fracture of the proximal tibia, or a Schatzker 6 are the most common injuries in the tibial plateau scenario to have sustained a neurovascular injury, in particular a vascular injury. So when you see those, you should be thinking about handling the patient just like you would handle this one, where there needs to be some level of reduction or stability conferred to the knee immediately, and there needs to be a high index of suspicion that they may have sustained a vascular injury. This is a really interesting case that I recently had. This was a patient that came to me kind of as like a third opinion. I want to say he was maybe 3 weeks out from injury, believe it or not. 16-year-old male, had sustained this injury, not skiing. This was an injury sustained this summer going over the handlebars of a wave runner, or jet ski. After questioning him quite a bit in regards to his mechanism, he clearly had a significant hyperextension mechanism. And the reason that I put this in is it's kind of in line with, the concerns that one might have with a Schatzker 4 medial condyle tibial plateau fracture. So here it looks pretty benign, right? You see the crack. He's reaching skeletal maturity, not quite there, but pretty darn close. And so this is kind of, if you will, a pediatric fracture through the growth plate. but it's also, you could say, very, it's essentially a Schatzker 4, given that he's near skeletal maturity. But in this X-ray, everything looks pretty well aligned. That, hey, that's fairly well reduced, not a big deal. That fracture probably needs to be fixed surgically, but doesn't look too bad on X-ray. So when I saw this patient initially, he was quite swollen, quite painful. It was difficult to perform any kind of stability exam on him in clinic. He was even at 3 weeks or so out of his injury. And so we elected to proceed with more advanced imaging, both CT scan and in particular an MRI study. And at the time of his MRI, it showed a multi-ligament injury of his knee. So he had completely wiped out the posterolateral corner. He completely wiped out his posterior cruciate ligament. So that's difficult, because now we have a tibial plateau fracture. We also have a multi-ligament knee injury. And it can be oftentimes very difficult to perform all of that at the same time, because you're dealing with technical considerations. The fracture needs to be stabilized, but that fixation may interfere with any kind of ligament reconstruction that you may be doing on the knee. So the way that we managed him is that we staged it. So we took him to the operating room and we stabilized his fracture initially. At that same time, we performed a posterolateral corner reconstruction. So we repaired and reconstructed the lateral side of his knee. And what that means, posterolateral corner, is that we reconstructed his fibular collateral ligament, and then we also reconstructed the popliteus tendon, if you will. And so it's a little hard. The convention has really become, when you have these multi-ligament knee injuries that involve either the medial or lateral side of the knee, in order to confer immediate stability to the knee, it needs to be addressed surgically typically. And that's oftentimes not just a repair, but a reconstruction to ensure that it's going to work and last. So that was the first stage of his procedure. We allowed that fracture to heal, and then came back approximately 4 months later, removed the screw fixation from his fracture, and then went ahead and performed a posterior cruciate ligament reconstruction. And that's what you're seeing the x-rays of here, is simply the fixation devices for PCL reconstruction. When I do a PCL reconstruction, I'm using what's called the anatomic technique. So it's a double bundle reconstruction. The posterior cruciate ligament is quite a bit different from the ACL in terms of what you're trying to accomplish at time of surgery, but we use an Achilles tendon allograft typically. And then we also use a hamstring allograft. So all allograft, we usually don't use autograft in PCL reconstruction. And so there's 2 bundles. You can see the tibial tunnel here that both grafts are placed through. So both grafts are placed through here, but they have separate tunnels and insertions on the femur. What you're seeing here is the fixation for the Achilles graft. And what you're not seeing behind this is there's an absorbable screw that holds the other graft in place to kind of, if you will, reconstruct both bundles of the posterior cruciate ligament. But this was an interesting case because it seemed like a very straightforward tibial plateau fracture on presentation. But after exam, it was clear that he had sustained a much more significant injury, and likely at the time of his injury, he had significant deformity of his knee that had occurred. I would suspect he had major hyperextension and a varus moment. He had paresthesias in the distribution of his perineal nerve. Those have largely resolved, and he was fortunate enough not to have sustained a vascular injury, but he very well could have. And so we did do a CT angio of him to make sure that there wasn't anything there, because he was having just some leg pain and paresthesias 3 weeks out after his surgery. And I was a little worried about kind of an occult intimal tear. I've seen a couple popliteal artery injuries where they developed a subtle pseudoaneurysm, and they really didn't become symptomatic from that until they were 10 to 14 days post-injury. So I'm always, when I know there's been significant deformity of the knee at time of injury, my suspicion for a vascular injury and kind of apprehension surrounding that certainly goes up. And so I become quite more fastidious, making sure that we've dotted our I's and kind of crossed our T's in that regard. So with that particular injury, the Schatzker 4, you always want to have a high index of suspicion of major deformity of the knee having occurred at the time of the injury and significant instability of the knee, which is very different than a Schatzker 1, 2, or 3. Those injuries, there can be deformity, but it's usually not nearly as significant as the Schatzker 4 or Schatzker 6. So vascular injury, present in up to 16% of knee dislocations. Incidence is 2% in all comers of tibial plateau fractures, but like I discussed, the most common scenario for that is in type 4s and 6s. So anytime you see that patient, you need to have a much higher index of suspicion. The way that we should examine for that and kind of evaluate it is that we need to be able to palpate the pulses. And if the pulses are not palpable immediately after the injury, that patient is not a patient that we should be waiting on. I would love to take care of that patient, but the apprehension I have about that patient is that we do not have vascular surgery here at Park City Hospital. And there is definitely going to be a window if they've sustained an acute vascular injury, obviously, where they're at risk for losing their leg. And so if you're suspicious at all, like if on initial presentation of one of these patients, that obviously is a patient, I'm sure you all do it all the time, where it's not even a phone call. That patient is just on their way to IMED, the U, somewhere where they can be seen and addressed by a vascular surgeon. Now, if the pulse is palpable, but it's weak relative to the other side, what's recommended is ABI evaluation. And if it's less than 90, you proceed with further evaluation. If it's greater than 90, your suspicion can drop. But I personally, if you have any suspicion of a weak pulse, my thought is straight to CT angio. ABI is a reasonable thing to do, but there's, in my opinion, some subjectivity to that. Even having that done on my routine annual physical, I see variations in the numbers that are generated. And so it's hard for me to have a lot of confidence in that. So I don't think, if you were asking me if that's going to be reliable information that you can make a decision on that could potentially have somebody's leg, the viability of their leg and the balance of that decision, I think it's CT angio. So if there's any discrepancy in your vascular exam, I think that's a patient that needs further evaluation. If the pulse is not palpable, I think they go obviously straight off the hill. If it's palpable, you just have a question, that's an immediate transfer perhaps to Park City Hospital where a CT angio can be done. But I think if your index of suspicion is really high that they could have a vascular injury, then they go straight to the trauma center. It's just not worth it. The beauty of orthopedics, as you well know, is that we always have the other leg to compare to. So don't be afraid to do that if you have questions about their vascular exam. And just an emphasis on the type 4s and type 6s. Compartmental syndrome. This is something that should always be on our minds when we're looking at a tibial plateau fracture, especially the higher energy ones. 10% incidence in tibial plateau fractures. I have seen them in particular in split depressions and split lateral condyle tibial plateau fractures, so the type 1s and 2s, but they're just not that common. So in that scenario, but they certainly occur in 4s, 5s, and 6s. And as you know, it's not always something that is present immediately on presentation. Oftentimes it's escalating and it can develop within 12 to 24 hours or even 48 hours of the initial injury. And so it's just something to be mindful of, but probably isn't going to be present right at the time that you see the patient. Most of their pain at the time that you see them is going to be due to the instability of their fracture pattern, not likely to compartmental syndrome, but the higher energy ones are always at risk for it. And it's always something that we're kind of mindful of and looking at. So you don't have to be too worried about it at initial evaluation. That's more a concern for us once we have them and they're admitted and we're observing. When I'm suspicious for compartmental syndrome, the most sensitive exam finding, I think, is to just gently move their toes, stretch the muscles and see how they respond to that. If they're just wincing and come right off the table, certainly index of suspicion needs to go up, and that's where we might bring out the striker pressure monitor. But if they're really clinically demonstrating signs of it, they're on their way to the operating room getting fasciotomies, and we'll simply put the striker pressure monitor in their leg as kind of a formality at the time of the procedure. We oftentimes talk about paresthesias and diminished pulses, as diagnostic signs of compartmental syndrome. These are late signs. And so if a patient has gotten to the point where they have diminished pulses, or they're having significant paresthesias due to compartmental syndrome, the cat is probably well out of the bag and they are probably experiencing active muscle necrosis. or they may even be at a point where they have completely necrosed a compartment. So these aren't necessarily diagnostic signs at the time where the patient has a reversible condition. These are late signs. So I put this on here just to remind you all, and I think you all probably know, but most of the patients that have these highly unstable fracture patterns, Schatzker 4s, 5s, 6s, and those split depressions where the knee has significant deformity, this is always what's going to happen initially with that patient. They're almost always going to get put in a spanning external fixator so that we can monitor them for compartmental syndrome. We don't want to increase the likelihood of compartmental syndrome by doing an open operation on them immediately. We also we want to allow for soft tissue swelling to recover a little bit, because the more significant swelling is going to be 48 to 72 hours after their injury, as it relates to potential fracture, blistering, etc. And so if we put an incision on the skin right away, the risk of that patient going on to develop wound healing complications, infection complications, etc., is escalated quite a bit. So these patients all get put in a spanning external fixator initially, and then we're coming back depending on how much they swell. We may come back as soon as 3 to 5 days after the injury, but it can be up to even 21 days after injury. And so that's where we have a lot of pragmatic challenge with some of our visiting patients from all over the world. When they sustain these injuries, they're all of a sudden in a situation where, you know, they can't get home easily. And so they're kind of camping on us here, sometimes for 10 to 14 days. Sometimes all those days are in the hospital as we kind of navigate these injuries with them. So, but with that, I'll wrap up. There's obviously a lot more I'd love to share with you guys about these injuries. They're a challenge, but really interesting for me to take care of, and I do enjoy taking care of them. And so there's obviously a lot more discussion we could have about kind of surgical treatment of these injuries. But with that, what questions can I answer for you, or what thoughts does anybody have?
Hey, Charlie, just a quick question, but if we see a patient in a ski clinic and they're from out of state, it sounds like a Schatzker type 1, 2, and 3 can be put in a knee immobilizer, can probably go home for the most part, unless it's more trauma. 4, 5, and 6, would you always send those to the ER for a CT scan and to get you involved a little bit earlier?
I think you're always safest to do that with the 4, 5s, and 6s. I would say always on the 4s. Always on the 4s. And the reason I say that is that, especially if they're pretty painful, the reason I say that is that just like that X-ray I showed you of that 16-year-old, I mean, I am sure the amount of deformity that extremity sustained at the time of his injury was significant. And so I think you just have to assume that those Schatzker 4s are highly unstable, and there has to be a suspicion of nerve or vascular injury. And so it's pretty hard to put that patient in knee immobilizer and allow them, I think, to get on an airplane and return somewhere. So yes, I would agree with what you said. Now, Schatzker 5 sometimes, those can be pretty stable, actually, especially if they're minimally displaced. So I think there's some discussion with a kind of non-displaced Schatzker 5, but if you have any doubt, for sure, send them for a CT and so forth. I mean, they're all going to get CT scans anyhow. But the 1s, 2s, and 3s, yes, for the most part. However, the deformed Schatzker 2, where the lateral femoral condyle has really kind of depressed into the tibia, and they're in significant valgus malalignment, those are pretty unstable fractures, and most of those we will put in an X-fix. So I think if they've sustained significant deformity, Schatzker 2, significant articular depression, that's a highly unstable injury. The Schatzker 1, the Schatzker 3, most of those you could certainly give a trial where you can put them in a knee immobilizer, and if they're reasonably comfortable, no apparent neurovascular issues, those are going to be a little safer to say, hey, you have the option to travel home and get in and get seen and evaluated ASAP at home. But the deformed 2s, 3, 4s, and 5s, yeah, I think those are ones that should have a little more discussion before we put them on a plane. The other thing I might mention is that with DVT prophylaxis, post-surgically, we're putting all these patients on a minimum of 2 weeks of Eliquis, 2.5 milligrams BID. I think if they're traveling with a tibial plateau fracture, I think all those patients should be prophylaxed in the same way. Eliquis is easy to reverse. You can stop it essentially within 48 hours and feel very comfortable about proceeding with surgical treatment, even on the 5s and 6s where you're making big open incisions and dual plating. So I would have a low threshold to prophylax those patients if they are going to travel, even if they're a simple Schatzker 3.
Quick question, with that external fixation device, and these guys are out of state, how long between the X-Fix and the definitive surgery? Do these guys travel back home, or do they stay in Park City?
I've done both. But I'll tell you, the pragmatic challenges of traveling with an external fixator, there are no easy solutions to that. And a lot of patients, when we initially see them, have the ambition to travel with it. And then they get the X-Fix placed, the leg becomes more painful. They recognize the pragmatic challenges and they are in no mood to travel after that. And so I would say 80+% of these patients that initially think they're going to be traveling, once it's stabilized with an X-Fix and are in a hurry to get home, which all of us probably would be in this scenario, oftentimes make the decision to stay. So I think 80% of these patients end up staying and having their definitive surgery with us.
Wow.
They can travel with them though. I mean, I've had patients return to, England. I've had patients return to Toronto, Canada that I can think of with external fixators. And every now and then we get, more fortunate patients that fly privately, and obviously that's a much more friendly situation to traveling with an external fixator. So every situation is a little unique, but I feel like most of them do end up staying because it pragmatically it's just really difficult.
Well, Charlie, I know you've got to get to surgery. Can't thank you enough. If anyone else has a question for Charlie now, that's great. If not, if you get them to me, I'll get them to him. So thank you so much. That's really, really helpful. And I'm sure we'll be talking to you very soon.
Right, exactly.
All right. Thanks, Charlie.
Thank you.
Thanks,
Thank
y'all.
you.
Have a good day.
Okay, bye-bye.